Hey guys, Woodruff here. Now let's talk about Foley catheters. So this is a good question to start off with because a lot of people are confused about who actually qualifies for a Foley catheter. There's a short criteria list, and of course it might vary by facility, and there are sometimes special occasions or special times this happens. But the use of Foley catheters has declined over time because of the high risk of CODIs or catheter-associated urinary tract infections. So it's really important as the nurse to know when it's appropriate to ask for a Foley. And then just knowing that as the nurse, most hospitals have what's called a nurse-driven protocol where they have and like me as a nurse, if I go in and someone does not meet the criteria for needing a Foley anymore, I can take it out without a doctor's order if I'm at a hospital that has a nurse-driven protocol. We'll talk more about that. But anyway, so let's look at this question. It says, which of the following client scenarios would be an appropriate time to ask for a Foley catheter? So A says the client is going to the operating room to get a bladder reconstruction. So most people would say, ooh, anytime they're going to the OR, they need a Foley. And the answer to that is actually nope. It depends on the procedure, how long it is, etc. But if they're going to have any sort of abdominal or bladder surgery, the answer is yes, that is an indication to get a urinary catheter. Now, most of the time they're going to place this if they don't already have one when they get to the operating room, but it's just good to know that that would be an appropriate time. So there are patients that have specialty urinary needs, and so like if I go in and my patient has what we call a urology Foley or a urologist placed it, I'm not touching that thing until the urologist themselves tells us okay, it can come out, because those sometimes were really hard to place. They sometimes have to place those under special guidance or I don't want to say fluoroscopy, but maybe it is. Special imaging is needed sometimes in order to get those in. So I'm not about to undo someone's hard work. So always be careful too that, even with that nurse-driven protocol that I was just talking about, that you're not getting a little too pool happy and making sure you're not taking something out that needs to stay in. The next one is client is obese and has limited mobility and weighs 300 pounds. So most people would say, yeah, but here's the thing is that the answer here is nope. No amount of, being overweight, limited mobility officially is a, appropriate use for a client who is, who needs a Foley catheter. Excuse me. I'm sorry. I can't get a sentence out today. But here's what you want to think about, because when you're thinking about, well, then what are we supposed to do? Well, if they can't get up to the bathroom, then we can do the bedpan, or depending on like if they're a male, we could do a condom catheter. If they're female, we can do a PureWick. If you're thinking about, well, what if a lot of men have innies, and what I mean by that is that their penis kind of retreats into the scrotal area, or it kind of goes back inside, and it's not actually gone. It's just, especially when patients are obese, sometimes it's really hard. There's some patients that just don't have a long enough penis to fit a condom catheter. So, in cases like that, what I've done before in the past is I actually get an ostomy pouch, and I create a pouch on the outside of their penis that can still collect like a condom cath, but it just has a wider girth, because I don't have, that their penis either is inside and I can't get to it, or the penis is not long enough to fit a condom catheter. So there are other ways around it. And there's sometimes worst case scenario that I've had to just wrap them in pads and catch it there and then regularly change them. It's not ideal, and it's not fun, but we really want to avoid just putting a Foley catheter in everyone for our convenience. So A is yes, B is no. Client is experiencing acute kidney injury and is intubated. So this is like a critical care patient. This is another indication for a Foley catheter. And it's not to say every patient that's intubated has to have a catheter, because now, like with condom catheters and PureWicks, there's many times that we use these. But if we have a patient who has acute kidney issues and is, critically ill, especially since they have kidney issues, we probably want to keep a really close eye on their urinary output, which means I don't want to risk them being incontinent or other things, or not being able to keep track of how much urine is coming out. So this is a patient that would be appropriate because they are critically ill, and we need to closely watch their urinary output because of their kidney issues. Client has a stage 1 pressure ulcer on their coccyx. Well, there is some patients that do need a Foley catheter due to skin issues, but they have to have a stage 3 or stage 4 in order to qualify for the Foley catheter. So this one is a nope. Client is having regular incontinence and needs to be changed every 2 hours. Now this is sorry, that girl. This one is the one that most people would say this, like, oh yeah, if someone's constantly peeing on themselves, like I want to protect their skin, they need a Foley. And here's the thing, again, we have incontinent devices. So we have chuck pads, we have bedpans, we have PureWicks, we have condom caths. So there's other ways to provide continent, like, you know, at least capturing of the urine and protecting their skin without actually needing the Foley catheter. Client is on hospice or palliative care. This is another reason for a Foley catheter. So someone's end of life, hospice palliative care patients do qualify for getting a Foley. This is just to help to promote their comfort and provide for a good end of life experience for them and their family, to provide them with less pain. If this patient's constantly incontinent, we're having to move them around a lot, if they're having a lot of pain or other things, it's rather cruel. So we always want to keep that in mind. And then the last one is client requests to have a Foley catheter placed. That is not a reason. I've had, and believe it or not, people request these things. You probably think people hate them, and most people don't want one, but a lot of people want these things. So you'd be surprised. They're like, yeah, just stick a catheter in me. And yeah, that's not how it works. So I've had patients that have catheters in and refuse to let us take them out, and that's a whole other issue. But yeah, and keep in mind again, like these are some general rules and things like that. But you know, we always have conversations about these things because sometimes it's just, you know, we have to think about the patient's whole clinical picture. So like a good for instance is when I was working, I had this sorry, this noisy bitch. So he called excuse my language, kind of. This trauma patient, she was young, she was like you know, maybe like she could have been like 18, 19, or she might have been younger than I can't remember. But she was on the larger side, like 200 to 300 pounds. She was a special needs patient. She had been in a car accident and had like bilateral hip fractures, had a lot of issues. And she had a catheter in because she had gone to surgery to get something replaced. Now she was going back, like, you know, I think she maybe had one of her hips fixed, maybe had to have the other one fixed, or had, like, I don't know, she was broken head to toe. It was just a mess. So to turn her, to put her on a bedpan took like 6 people, and she was screaming excruciating pain, really hard to redirect because of her special needs issues. And it was such an ordeal every time we had to turn her. The doctor, this was a doctor that used to work at my hospital that constantly or always was trying to avoid getting a CAUTI or eclampsia under the name. In other words, they didn't want infection associated with them. So anytime, with every single one of their patients they took out, they didn't allow them to have any central lines. They didn't allow them to have Foleys. So she came around and she put an order in to take out the Foley. And, you know, so we had to have a talk with her because we're like, hey, listen, I even made her come to the bedside because at first she didn't want to listen. I was like, please come and see what it takes to when we were trying to get this patient. So I showed her what it took to get the patient on the bedpan, the screaming, and like she herself closed the door because the patient screamed at the top of her lungs, excruciating pain, and then like all of that. And we were doing like, because she was having to go to the bathroom, like because she was on IV fluids and other stuff, she had to go to the bathroom like every 1 to 2 hours. And so to put her through that ordeal and all that pain was counterintuitive and like made her recovery even worse. And she was going back to surgery the next day, so it made no sense to take that catheter out when, you know, in that situation. Now this is again, this is a story and this is a real thing that happened. By the way, we did end up getting to keep the Foley, even though it was an ordeal to have to ask for. And again, we had to like advocate, say, you need to come to the bedside, see this patient. This is not, you know, fair to this patient. This is cruel and unusual. You know, this patient needs this catheter, but this is just one story of a time. There might be exceptions. In other words, like I'm going to show you a list of indications for Foley catheters, and you should consider that, but also always consider your patient's individual situation. That sometimes we do have to advocate for our patients and think about what's going to be most helpful for them in this moment, because there are times that we go outside these parameters, but we want to make sure we're not just sticking it in for our comfort, our convenience, things like that. TED Talk done. Anyway, so the main indicators for a urinary catheter are going to be urinary retention. So anyone who is retaining urine, so that's like acute urinary retention, someone with a stage 3 or stage 4 pressure ulcer, anyone who's in a critically ill patient that we really need accurate intake and output to best take care of them, terminal illness, and certain surgical procedures as well. There's a variety of types of catheters. If you look at the top here, this is what's called a straight cath or an intermittent cath. And this is the one that we stick in, drain the bladder, and then pull it out. These two in the middle are some special ones that I'm not that familiar with, so I'm not going to try to pretend like I know. D is what we would consider a normal indwelling Foley catheter, has a balloon, a straight tip. This one, E, is what we call a Coudet catheter. And what this one is it has a little curve at the end. Think the Coudet is curved. It's specifically for patients with prostate issues. When the prostate is hard to bypass, that curved tip allows to make it easier to get past. And then this last one is what's called a three-way or bladder irrigation Foley. You can see here there's an extra port. All the others have these 2 ports. There's an extra port to do continuous bladder irrigation, which we'll talk about when we talk about prostate surgery. So just keep in mind with these Foleys, usually like what we do is we always are gonna, of course, before we put with some patients that are having kind of long-term retention, we usually try the intermittent first. If we're doing it frequently, they might end up with an indwelling. The Coudet is like if you cannot get a regular one in, or sometimes a urologist has to place the Coudet catheters, and then the three-way is going to be one that a doctor would place in surgery. I've never placed a three-way catheter. I'm trying to think. I want to say that my unit stocks them, but I could be wrong. But the other type of catheter we also have is sometimes called a Foley tip, and it looks a lot like this F. It has a regular straight tip with the balloon at the end. But it allows us to get like a core temp, and it connects to our monitor so we can monitor their temp all the time. So that's a good one to put in if you think your patient might have like abnormal temperature issues. There's intermittent catheterization, like I mentioned. This is what a kit would look like. You stick the catheter in, drain the bladder, and then pull it out. It is considered at most hospitals a sterile procedure, some places not so much, but you just want to kind of always keep in mind with this to try to be as clean as possible. Some patients go home and learn how to do this for themselves, but you want to keep it, teach them that aseptic technique and that sterile technique as appropriate or as ordered. There's different sizes to catheters, so much fun. And I know that there's like memes out that's like, be nice to your nurse, we choose your catheter size. And we really don't, because we don't stock a whole bunch of catheter sizes. Usually most of the time you're going to see, I want to say like we usually do 18 or 16 French, I want to say sometimes 18 French, just depends. But usually that's about the size that we're putting in. If you want to get other sizes, usually you're going to have to get like a urology tray or special from the OR. The Coudet, again, it helps to go past the prostate when the prostate is enlarged or we're having issues passing that. So you can kind of see that curved tip there. And then three-way is where, like, again, on one of the ports of the catheter, you'll have continuous irrigation where we're flushing out the bladder. So that's something else that we'll talk about more later. So one thing that for special consideration is what's called a suprapubic catheter. These are, like I talked about, for spinal cord injuries where it's a more permanent tube, and it comes straight out usually from your abdomen or straight from your bladder. These can be used short-term or long-term, and we're going to similarly care for them as for the Foley. But the other thing we're going to worry about is, of course, that that skin or that incision where the tube is coming out. We want to watch closely, make sure it doesn't get infected. We need to maintain gravity drainage with these, reposition it regularly, and we may need to milk the tube to prevent clogs. Now, I've never milked a suprapubic catheter, but it is possible that it could happen. Repositioning the patient and stuff like that definitely helps to get things moving. There is medications like that anticholinergic oxybutynin that we can give if they have bladder spasms. And then the catheter, if they have a suprapubic, they usually need to change it monthly. So my biggest concern with urinary catheters, of course, is infection. So daily care is key to preventing this. Know the signs and symptoms of a UTI. And since they might not be having the symptoms, they might have burning even with the catheter in, but we want to be looking at their urine. Is it becoming cloudy? How is it changing? And then also the tubes can become dislodged or become blocked. And then usually in that case, we need to remove and replace them as it's prescribed. So what's my role as the nurse for a urinary catheter? I don't want to break the seal or disconnect the device. And what I'm talking about there is what you're seeing here in this picture. So modern Foley catheters, like every Foley catheter you use that's placed in the hospital, because sometimes people come from outside with their own Foley catheter, so those might be different. But when people get a Foley catheter in the hospital, it's going to have this red seal on it. And what that seal tells you, it's like it's tape and it's perforated. Not tape, sorry. It's like plastic and it's perforated. And it should be intact. Like that tells you no one has disconnected the catheter from the bag. So this is what we call a closed circuit. We want to keep the circuit closed because that means once you insert it, there's no other way bacteria can get in because that circuit's closed. But what happens sometimes, you know, in the past, we don't really do it anymore, is we would disconnect this red part and then flush the catheter and try to get things flowing if there was issues. But now we really don't routinely do that. I should also mention there's other ways and places to do that, like through the sterile hub too. But we don't routinely do that anymore. So I actually, like when I chart my daily assessment of my patient, I'm charting that this seal is intact. So it's a part of my nursing assessment that when I'm checking my catheter, I'm making sure that this is intact. Oh my Jesus mushrooms, sorry. And so I'm charting that this is intact and that it hasn't been broken. Because again, that just kind of what that tells me is that patient's at higher risk for infection because someone has disconnected this. Now, sometimes it's going to be without a seal. Like if I have a urology Foley or if someone put a Coude catheter in, we don't have Coude catheters that already come attached to the bag. So we have to put the catheter in and then attach a bag. So it's never going to have a seal, but I just need to document tamper seal not intact. And so that it's already known that it could be a potential issue. But I'll tell you this is that there's been times in the past where I've come in and someone has broken that tamper seal and they've actually made me taken the whole Foley out and put a new one in so that it has an intact tamper seal. Now I know you're probably thinking what I'm thinking is that wouldn't it create more infection taking one out and putting a whole new one in? But they actually say having that tamper seal not intact increases the risk of infection beyond sterilely putting a new Foley in. So interesting stuff. We always want to keep the urinary catheter bag below the level of the bladder so to make sure for adequate drainage and to try to make sure things are flowing in the right direction. If it's not below the level of bladder, it can back up and then the urinary stasis can happen and infection can happen. We want to do regular perineal and catheter care Q-shift. We usually do this with chlorhexidine for good cleaning. And we want to clean all around that tube and then also do perineal care. An anchoring device like this, so we don't want any sort of tugging to happen with a urinary catheter. So we use a device like this. It's called a stat lock. It helps keep it in place. We want to remove the catheter as early as possible. If not, we of course want to be changing them out regularly if they do need a long-term Foley. No lotions or powders in the area, and we want as a part of our job as the nurse, we're going to record accurate intake and output because that's usually the main reason that we have this in is so we can get very good accurate intake and output. And then if we need to get samples and stuff, we get it from this lovely port over here, and I'll talk more about that when I talk about UTIs. I think that's it. Okay, that's it. We're going to talk about urinary diversions next. See you for that one.